Open, this hearing of the Senate Community Affairs References Committee's inquiry into the issues related to menopause and perimenopause. I begin by acknowledging the traditional custodians of the land on which we meet and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. The committee will be conducting today's hearing in person and via video conference. I'm Senator Penny Orman-Payne and I'm joined in the room today by Senators Wendy Askew and Senator Larissa Waters. Senators Smith and Pratt are also joining us today via video conference. These are public proceedings being audio streamed live via the Parliament's website, and a Hansard transcript is being made. I remind all senators that as we continue our work implementing the Set the Standard report as chair, I will ensure that proceedings are conducted in an orderly, respectful and courteous way. Real and perceived conflict of interest can negatively affect public confidence in the integrity of inquiries. As such, the committee encourages all witnesses participating in the hearing today to declare to the committee any matters, whether of pecuniary or other interest, where there may be or may be perceived to be a possible conflict of interest. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer, having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. I remind committee members and witnesses who are appearing via teleconference and who are not speaking to please mute their microphones. Further, I take the opportunity to remind all witnesses to ensure that their opening statements do not exceed 3 minutes, in order to ensure that all senators participating in today's hearing are given the opportunity to ask questions. Thank you. I now welcome representatives of Wellfem, Her Health and Aesthetics and Meno Doctor who are joining via video conference from New Zealand. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, will you please state your full name and the capacity in which you appear today? And I'll start with the people from Meno Doctor who are on video conference.
Hello, can you hear me?
Yes, we can.
Wonderful. My full name is Linda Deer. I'm a GP and menopause practitioner based in New Zealand, and I'm the director of Meno Doctor, a private menopause clinic here in New Zealand.
Thank you. And I just note for the witnesses that are here, we have media in the room, if people are comfortable with that. Yep. All right, thank you. I'll now go to people at the table.
My name is Dr. Virginia French. I'm a primary care physician and I have a business in women's health called Her Health and Aesthetics. I provide menopause care and other women's health subspecialty care.
Dr. Kelly Teagle. I'm the founder and director of Wellfem Telehealth Menopause Clinic. I'm a GP.
I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to... Oh, I've done all that. Sorry, it's been an early start. I now invite you to make a short 3-minute opening statement, and at the conclusion of any remarks, I'll invite members of the committee to ask questions. And again, we'll start online.
Okay. Menopause is a biological certainty. And although for each woman, menopause will have different symptoms, ranging from none at all to debilitating, come at different ages, and have different causes, not every menopause is natural, despite this variety of experience, it is a truly unifying event that all women share. But sadly, it often ends up being a really lonely and confusing time. That is what I've heard from patients in my clinical practice over the years. It's what I heard from the over 5,000 Australian women who completed my survey, and it's how I felt myself when I started to get perimenopausal symptoms. Too many women either don't even know it's happening, or they do know, but they don't feel able to talk about it, so they suffer on alone and in silence. So we have at least two big problems to sort. One, the stigma and silencing of menopause, and two, the lack of good information reaching people, women and doctors. In terms of the first problem, there are messages out there, some coming from large healthcare organisations, saying to women, menopause is easy for most of you, so don't talk too much about it and don't be too negative about it, or you will look weaker than men in the workplace, you will frighten your fellow younger women, and you will help scrupulous businesses cash in on menopause. And I'm talking here about the ones who are ripping women off with remedies that don't work and hormone tests that are pointless. So in the face of all this, what do women do? We put the brave face back on, we keep stum, and we stay lonely. The second problem is information. It used to be a total lack of information out there for women and doctors. And this is still the case in a lot of places, especially in healthcare. And often women themselves are not aware that perimenopause can start around the same time our fertility declines, which is from age 35, or that hormone changes can cause all kinds of symptoms. You don't have to have hot flushes or a dry vagina. But on the flip side to that, we've also got this avalanche of information, and some of it's good and some of it's bad, and it can be really hard to tell the difference. There's also a lot of mixed messages and bickering going on, and women are stuck in the middle just trying to figure out what's best for them. You've got people saying we're over-medicalising menopause and HRT and testosterone prescribing is out of control. You've got other people saying we are under-medicalising menopause and women are getting fobbed off by their doctors, denied HRT, and being told it's all just the stress of midlife. So the information is too confusing, the experience is too lonely, and until we do something about both these things, women will continue to feel fobbed off, ripped off, and quite rightly, pissed off.
Thank you. Dr. French.
A woman knows her body, but when she attends her GP to explore perimenopausal symptoms, she is often rebuffed. Her experiences are not validated. She is frequently not offered informed discussion about the biological changes in her body, nor offered appropriate management options. And by this, she is disempowered. The result is a woman may not further pursue treatment. She is left believing that she must tolerate her symptoms or accept a treatment, often an antidepressant, which she does not believe to be appropriate for her. To cope, she may try reducing the more taxing areas of her life, which will often be her work. She may leave her job, reduce her hours, take unpaid leave, use long service leave, or commonly reduce the role and remuneration of her position to reduce her stress. So not only is she left unsupported and suffering treatable symptoms, she is also unwittingly generating future social and health vulnerability. Consultations about menopause transition symptoms are complex. They require that the health practitioner, who is currently more likely to be a GP, listen, validate, and educate. The practitioner's knowledge must go beyond the PBS-listed indications for medication, but extend to the potential benefits and risks of off-label prescribing and non-pharmaceutical management. The practitioner must be able to explain and tolerate the uncertainty of a changing evidence base, and this communication needs time, empathy, and a willingness to support a woman's autonomy. The consultation must be free of personal judgment and opinion. To make a fundamental change, there needs to be a system-wide approach. Re-educating health practitioners is essential, but it is not enough. Change will require adequate fiscal remuneration for these long, more emotionally demanding and possibly medically challenging consultations. The predominance of female practitioners currently performing this care is widening the gender pay gap and increasing the care burden that female practitioners experience. There must be parameters in place such that practitioners who cannot deliver this care support access to a practitioner who can. and there needs to be equity in the expectation that both male and female practitioners do provide this care. There must be a move away from patriarchal prescribing patterns, shifting the decision-making from the practitioner to the woman. PBS subsidies should reflect current medication safety profiles and demonstrate by their application that women's health matters. And when a woman finally accesses her preferred treatment, the product information sheets should be accurate and in keeping with current prescribing guidelines. The journey should be shared, cohesive and supported.
Thank you. Good morning, Senators. It's an honour to be here. And I'm going to preface my statements by acknowledging that not all people born with ovaries identify as female. So when I refer to women, please understand that I'm meaning to include everyone born with ovaries. So by way of declarations, I'm the majority owner of WellFem, which has provided essential medical services to peri and menopausal women for almost 6 years. During that time, I've gratefully accepted funding from private industry to help keep the lights on. I'm also a proud member of the Australasian Menopause Society. I'm here today not only as a menopause doctor, but also as a woman with my own unique menopause story. I experienced the debilitating symptoms of a particularly early menopause at age 42, and then again 10 years later when breast cancer threw me into a second menopause. These experiences inspired my practice and sparked a desire to improve menopausal women's lives. I met more and more menopausal women, some of whom had travelled quite long distances to get help, so the idea of delivering consultations by telehealth gradually developed. This was a bit of a hard sell when I first got started back in 2018, but during the pandemic, telehealth quickly proved itself as a valid way of delivering medical care to isolated people. The health system quickly adapted out of necessity, but the benefits of continued telehealth access for our community are now well established. Now, in recent years, we've seen a rapid growth in demand for menopause-related services and information. Existing women's health services have been overwhelmed. Public health systems are scrambling to adopt new models of care, and new commercial operators are appearing to fill those gaps. These various service providers often seem to be jostling for reputational authority, but the reality is that we need a wide range of different support options to suit different people, both publicly and privately funded. Motivated professionals who do good work can best serve our communities by a collaborative approach that effectively shuts down any unscrupulous operators. There's a lot of great menopause work being done around Australia, but often in a siloed and uncoordinated way. Split funding arrangements between federal and state can lead to duplications or gaps in effort. The seemingly random allocation of research funding appears to have no strategic plan, and the roles and scope of various menopause-related organisations are often unclear to consumers and health professionals alike. My main overarching recommendation to this committee is that we need a national menopause action plan, a coordinated strategy shaped by key stakeholders from all spheres. We have a historically unique opportunity here to improve long-term health outcomes. Menopause is a physiological trigger for chronic diseases which eventually result in loss of function and independence. So if we get this right, if we can take a unified approach in our efforts, we can facilitate timely interventions at midlife that will hugely reduce the burden of future chronic disease and improve women's quality of life in older age. Thank you.
I'm going to go to Senator Waters.
Thanks very much, Chair. Good morning, everyone. Thank you so much for the work you do and for the work you do across the seas as well. Really appreciate your time. Looking forward to today. Can I start off, Dr. Teagle, with your suggestion for a national menopause action plan? What sort of things do you think such a plan should address, and how do you think it should be rolled out?
Yeah, that's a very good question, and it's something that's been addressed several times. We discussed it at the roundtable on menopause last year. It was in our pre-budget submission and in my submissions as well. So there are a few different things in terms of funding, coordination, making sure that efforts are unified and very strategic. I've listed in my submission. The stakeholders involved might be people, for example, who are involved in policy development and the provision of advice to government, the design and execution of research, the examination and interpretation of evidence for clinicians and the public, the development and delivery of clinical education to health professionals, the development of network systems to support GPs in their local communities, the development and execution of an integrated national plan for service delivery to public patients, utilising a combination of telehealth and in-clinic options, and facilitating and overseeing the supply of affordable and evidence-based medications. So these are examples of the types of stakeholders that we need to bring together to make sure that everyone has their say in how these things can be effectively coordinated and implemented.
And would you see it as a plan that would cover all aspects, the health aspects, the work aspects, the kind of personal life wellbeing aspects, and would it be at the federal level, and how would you see states and territories being operationalised?
I do see it as being at federal level in terms of an overarching plan, for sure, with representation by the states, definitely. So, I think that it needs to be well coordinated. I'm sorry, what was the first part of your question?
That is an excellent question. How broad should it be? What sort of things should it cover? Health and work and personal, or just a specific?
Look, I definitely think so. I think, and I think by keeping the involvement of stakeholders, from all these different areas, it's going to naturally encompass all of that. The very things that this committee has been examining during the inquiry, for sure.
Okay. Now you made some very interesting observations about effectively the gender pay gap within, in fact both of you did, within service delivery, particularly in women's health, and you made the observation that longer consultations actually get remunerated less for the doctor on a per minute basis. So essentially it's incentivising having lots of shorter consultations rather than incentivising having a nice fulsome consultation where a patient can really divulge all of the things they need to in order to get top quality treatment. So can either of you reflect on how we could address that gender, what is effectively a gender pay gap in the MBS rebate system? And just elaborate on that a little if I've minced it there.
At the moment, if you want to use a parallel, the mental health care plans do have a slight increase in the remuneration rate through Medicare and requires that you complete a competency assessment for that. And a similar concept could be used for this type of consultation where if a doctor has completed some accreditation that's recognised by Medicare, then that might open up a different Medicare code that offers a larger rebate for those specific consultations. Now, that might be limited in number per year in order to make it sustainable for the country, but it could be a separate type of consultation with its own Medicare number that is uniquely higher in subsidy.
That's a very interesting concept. In the most recent budget, and someone will correct me if I'm wrong, I think it was the most recent one, there was a 60-minute consult that was introduced. Now, pardon me, I don't have the details to hand of what it's covered, but I think it's just a time-based consult rather than an issue-based. Yes. Do you see that as being relevant here? What more needs to be done?
The remuneration for that 1 hour consult would still make a practitioner who's doing long consultations earn about half as much or less as another doctor who's turning over 10 to 15-minute consultations.
One of the problems that we've raised before is the fact that these time-based consults are not consistent across the whole duration of the consultation. So, if you're turning over rapidly, seeing lots of patients, you could, if you were bulk billing, you could earn $6 a minute. But then by the time you're doing, 50-minute consultations, you're earning less, $2 or less per minute. Yes. So the problem is not just having, a dedicated Medicare item number, say, for a comprehensive menopausal health assessment, which we could do as similarly to what we do the chronic disease plans. It's that female doctors tend to see more of the female patients doing these sorts of longer holistic consultations, and they're not adequately rebated per minute over those times. So if you're going to have a time-based system, it needs to be equitable across the length of the different types of consultations.
Yes. What is the policy justification for making the last few minutes worth less than the first few minutes? I don't quite understand the distinction there.
Good question.
Okay,
It's initiated by a patriarchal system, which is algorithmic and logarithmic. So you come in, you have problems, you solve it. This is how long we think that problem should take to be solved. And it's less involved with emotions and feelings. As soon as you start talking about feelings and emotions, you need time.
Yes.
And that doesn't conveniently fit in 10-minute segments. And that is why women end up taking that on.
Yes. Well, that's a very interesting observation. Thank you. I support fixing that. And I just to your suggestion of a specific MBS item for a menopause health assessment, that we've got a midlife health assessment at the moment, which I think is a 45 to 49 age parameter, which obviously wouldn't cover everyone in peri and meno, but it could perhaps cover a large amount. Are you suggesting that that health assessment could be used, or are you suggesting that we have an additional menopause-specific MBS consultation item?
I think that first one should be used as the initiator of the conversation. So currently there is no requirement on that you mention perimenopause. So that would be an essential. To get paid for that health assessment, there must be some acknowledgement that you've asked about perimenopausal or menopausal symptoms if the person identifies as female. Yes. And then subsequent from that, you would then trigger the need perhaps for a menopause care plan.
Yeah, the 45 to 49-year-old health check is available to not just women, it's available to everyone in the community, I believe, that it's designed to help anyone who is at risk of chronic disease. So that's obviously a very important thing, but it might be that, you know, doing that very broad medical assessment that you identify this woman is highly likely perimenopausal. I do see the value in perhaps having a dedicated, menopause-related consult item that might be open to anybody from age 40 to 50, for example, to be able to do
or
a
even
menopause.
30 to 60 for that matter.
Yes.
Potentially.
Okay, that is very useful. Thank you. Now I might move to. Oh, actually, there's one other point before we move to the doctor online. I think it was yourself, Dr. French, that suggested that we need to tackle the fact that the PBS isn't actually applying to many of the more modern menopause and perimenopause treatments, and that it's obviously driven by Big Pharma themselves seeking to have a PBS listing, which is sort of leaving us all at the mercy of pharmaceutical profits as to whether we can get healthcare, which does my head in every time. What is your suggestion for how we encourage better provision of medicines within the constraints of the system that we have, or completely fresh ideas welcome as well?
I think there needs to be federal involvement in the access to medications. I think it is up to pharma to justify whether they think our market is big enough, whether we're worth it, the effort for them, that there needs to be some facilitation and assistance offered to access go through the TGA approvals and apply for PBS funding. And it needs to be based on promoting what is safest for women and not what is financially most viable. It needs to be from a safety-first attitude. And in fact, we would like to use removal of PBS subsidies to disincentivise the less preferred medication.
Thank you. Can I move now? And I'm quite interested in that because it seems very... I'm getting the wind up. Okay, come back to me if there's time.
Yes. All right, I'm going to go to Senator Smith.
Thank you so much. I'm going to start with Dr. Deer online. I can't see, but I hope we still have.
I'm here.
Oh, there you are. I've got you now. Thank you very much. I just wanted to have a talk to you about the importance of quality information for women to access. We've heard, numerous anecdotes over the course of the committee about not being able to get good quality information from your GP, and it's sending women online to chat forums and that kind of thing, which many women have told us have been very helpful, but of course there's no way of regulating or verifying the information being shared. So I just wanted to go into this point with you, what sort of forums or platforms or opportunities do you think would be valuable for us to provide women, in addition to, of course, good quality primary care?
So, information is key. And as I said in my sort of little opening statement, it's kind of, in a way now, we're getting a bit overwhelmed, I think, for a lot of women. And, you know, you can end up with too much information after having too little. But there are some really good resources already out there. I mean, the Australasian Menopause Society is the obvious one to mention, because that is, you know, the society for you guys and for us here in New Zealand. And there's lots of fact sheets written for consumers, written for patients, as well as ones written for doctors. So that is a source that women can go to for trusted evidence-based advice. But sometimes there's another need that women have, which is for something with a bit more emotional sort of personality, maybe, and some of the medical stuff maybe does seem a little bit too clinical. And menopause is not just a medical thing at all. It is a holistic life event, and we need women to feel like there is this more holistic suite of options for them. So if there was some way for you guys to centrally create something that does incorporate a lot of the AMS stuff, because that's already there, ready to go. But then I think maybe there's another side that's missing a bit there, and that's for women who maybe don't want such a medical orientated approach to this life phase, because we shouldn't over medicalize it. That's true. And I do think a lot of these groups, yes, you can't verify everything, but women need that kind of peer support as well. That's really powerful. And yes, there'll always be differences of opinion and maybe what some people would call misinformation. But I think because this is not a disease we're talking about, for most women it's a natural event, although for some it isn't, then we've got to appreciate that women are going to have different values and different things they want, different ways they want to approach this. So some of the more natural things, although they get a lot of criticism and there are some scrupulous things going on, but it's about giving women options. So I think some of this sort of softer, less medical stuff is quite important as well. So you've got to try and balance all of that. But yeah, it's hard to centralize information. You know, the internet's massive, isn't it? You know, obviously. So, but if you want to put something out that will be part of something, I think, you know, involving AMS, but involving some other non-medical organisations as well, who can input into it, be part of it.
Yeah. Can I ask you about some of these alternative products? I mean, we have heard quite a bit of evidence around the efficacy or lack of efficacy of some of the products being marketed to women. And, you know, it's quite understandable when women are reaching out to these products if they don't feel like they're getting good care in the primary healthcare setting or good advice. They're looking for quick solutions, and there's a lot of marketing on platforms like Instagram. I mean, I get marketed it because I'm doing this inquiry. In New Zealand, I'm interested in how these products are regulated and if you are having the same challenges we have here in Australia. We've been told one of the reasons it's happening is because these products are regulated as food products and therefore may not be subject to the same kind of scrutiny that would be applied to other products regulated by the TGA. Is there anything you can share with us from New Zealand, good or bad, you know, which could inform our considerations of those issues?
I think, and I'm not an expert in regulations and that, but I think it's quite similar in that, you know, these products are here. They skate that line between medicine and food. You know, it's kind of that grey zone, isn't it? But they're often very careful in the wording that they use. And there are limits here, similar to with you guys, that you can't say it cures this, it fixes this. You can use more vague terms like it supports, it aids, it regulates. But, you know, is that misleading? Well, possibly. Is it a complete devoid of any research? Well, no, there is a bit of research for herbal remedies and things. So I don't think we can just poo-poo them all and say, oh, we should just, women, it's HRT and lifestyle changes and that's it. You know, I don't think that's really kind of quite accurate and helpful. And some women do find them beneficial. And yes, people say, well, that's just placebo. But, you know, there is a little bit of evidence, true, not much, not as much as we've got for pharmaceutical things in HRT. And the problem is a lot of women are being told bad things about HRT that aren't true, and that's why they buy the other stuff. You know, but as long as women are getting all the information, the proper information about all of it, then that woman is free to choose whichever thing she wants, whatever that is. So I think these other options should still be there. But yes, it's hard to fully rein them in. And they do push some boundaries a little bit and make claims that we're not allowed to make. You know, medicines are very restricted in what they can say. And yet it's the Wild West on the other side. They seem to be able to almost say whatever they want. So, yeah, women are vulnerable to all of that. And, you know, it's true, the worse the healthcare experience is, the more the women are just left then to potentially get thrown to these wolves. And there are some wolves out there, but they're not all wolves. But it's finding that balance. But I think any approach to menopause care has to be holistic, and it has to be not just medical. But we need the medical there as well, and we need HRT to be on the table, and women are not frightened about it or shamed away from it.
Thank you. I just had one more question, Chair, before I threw to Senator Pratt, and if I could just ask you to keep your answers short so we can get through a bit more. But there's been a number of suggestions to have a public information campaign on menopause. I just wanted to get a sense from you all, if that is something you support, who would this campaign be directed at, and what sort of information do you think it's important to get out there?
I'll start. Yes, absolutely. I think a public health campaign is really important for this reason, that women have been blindsided previously by perimenopause, just not knowing what's going on when it hits them. I think we need to make it sort of integrated, just the way we talk about other reproductive health or other health issues, other sorts of screening campaigns. You start to, bring it in well ahead of time, and then, target the key messaging to the people who are in that target age group. So that would be, anybody born with ovaries over the age of 35 really needs to be targeted there. And I'd say meet women where they are. Social media is where women are. That's what they're seeing. They're scrolling their feeds. They're getting all this messaging, good and bad. And if the government doesn't provide some messaging, then, they're going to suck up whatever they can find on the internet.
Thank you very much. I know Senator Pratt has questions. So, Senator, you.
Senator Pratt.
Thank you. I wanted to ask our Australian practitioners about my health record and if you're currently using it. And because I note, for example, it provides a place to record diagnosis and, of course, drugs. And you can see, for example, my own hormone therapy listed in it. But because, I'm presuming that because menopause is not a medical event per se, that it's perhaps not documented. Whereas when you use my symptom checker, it is actually really encouraging to see that the question is asked, are you post-menopause? So I'm interested to ask whether platforms like that, as they become more universal in documenting someone's medical history and, conversations between different doctors. It's not unusual, for example, to have, in my circles, to have a menopause doctor separate to your usual GP, for example. So I'm really interested to hear how we can, in addition to telehealth, and looking at a campaign, for example, around menopause, how we leverage platforms that can really help us understand ourselves collectively and as individuals.
It's an interesting point about the My Health record, and often women will come to me and actually ask that I don't tell their GP about the consultation, because they are often very loyal to their GP and they feel bad in some way that they've betrayed their GP, that they haven't been happy with the service that they were offered in regards to this topic and have gone to seek help elsewhere. So there's a bit of a consent issue around uploading to the
Although
common platform.
Clearly, surely you're able to counsel some of your patients around that. Do you automatically take that as a given and talk through the medical ethics?
If I ask a woman, would you like me to write a letter back to your GP, she will often say no. So it's an express consent question, and it's their choice. And that might just take a little time.
Yeah, I understand that. Yeah. But does that concern you? Surely that demonstrates deeper issues. Like, I find that profoundly concerning.
It is concerning because it means that the first person that a woman is likely to speak to about perimenopause is either not perceptive or not knowledgeable enough to address that well. And one of the things we could be doing is improving a GP's confidence in saying, this isn't an area of my competency or confidence. Could you please consult another person, and I'm happy to support you with that. But that's a mature conversation, and a lot of practitioners feel that if they haven't got some form of competency in something, that there is something deficient in them, which is not the case. But we need to have open permission for doctors to have clear boundaries about what they're happy to prescribe. A lot of GPs have their own opinions about menopause prescribing, which are actually very destructive. And so instead of being clear about their preference, they will actually redirect the conversation, duck dive and avoid, which just leaves the woman unvalidated and confused. So these are the complexities.
The basis for those opinions about menopause prescribing, are they based in science? Are they based in religion? Are they based in past evidence?
It's based in fear, because these doctors were raised in the time when menopause hormone therapy was bad, and because they've been in practice for a couple of decades, they haven't been in contact unless they're particularly motivated to do so, and we've talked about the barriers to that. They haven't been re-engaged. Very, very good GPs will still say family history of clotting is a definite contraindication to menopause hormone therapy. This is not true, but these doctors are good doctors who still aren't up to date with what is happening, and they are communicating these fears to the patients. I've had patients tell me that their doctor said it would be unethical for them to prescribe to her, that they don't want to give her cancer.
Doesn't this kind of bring us full circle in relation to things like my health record? Because it will be used as an evidence base. You know, we can see at a population level where it is used, trends in, you know, when women, for example, what age they start taking hormone replacement therapy, whether there's geographic biases in it according to which might show economic or cultural privilege in terms of those who are able to access it versus those aren't. In the long run, how could we use platforms like My Health Record to benefit both clinicians and their patients when it comes to support for perimenopause and postmenopausal patients?
So WellFem doesn't currently use the eHealth record system, basically because our clinical software provider is not linked into it yet, but it has been raised with them and we're working on it for sure. Going back to what we were talking about with the potential for a Medicare item number for a comprehensive assessment, that would be a really great opportunity if we rolled it out equitably and, you know, got a very broad cross-section of the community to have those assessments. If we could come up with, a really good validated, standardised kind of way of assessing symptoms and recording the types of things that were prescribed for women, and then following up the results of those and the trends over time with their symptoms, that's a great opportunity for a research tool right there. And there is a lot of great work being done. But currently, for example, we do menopause symptom score based on the modified green scale, which is, it's traditional, it's been around for a really long time, but it's woefully inadequate in terms of the broader cross-section of symptoms that women get. So yes, there are opportunities there definitely if we standardise the platforms, for sure.
Thank you. That was a really helpful exchange.
Can I make a small addition to that? Is just to also ensure that they're secure. I think there's some doubt around information and data security.
Absolutely.
Senator Askew.
Thank you, and thank you very much for your evidence and your submissions to all three of you. They were really well written and provided lots of valuable evidence. Just wanted to go back to something you said earlier in regard to the PBS and the TGA, and you mentioned the safety of products, and I just wanted to clarify what you were actually meaning there, because obviously any product that has gone through the TGA should be treated as safe, and then whether it's funded through the PBS is another matter. So I'm a bit concerned that implication was there. I understand that perhaps the unregulated products may be more in that unsafe or unproven area. So I just wondered if you could clarify what you're actually mentioning about that before I just move on to some of the points.
I actually meant that when we're prescribing menopause hormone therapy, we've got information that some products and methods infer less risk long-term than others. So you can strategise risk based on the individual's personal history and preferences, and you have the opportunity to minimise long-term risks or adverse outcomes by choosing certain products, but those products are not universally approved by Medicaid. The biggest one is micronized progesterone, which isn't currently PBS subsidised, but also transdermal gel, for example. So what we would consider the safest form of menopause hormone therapy is not reflected in the way that the government subsidises it, whereas the oral combined synthetic progestin menopause hormone therapy, which of course has an important role but might be second choice, is actually the one that holds the least expense for the patient.
So that's a matter between the government and the farmer at this point? Is that where that's at, as in regard to pricing?
So if we can't change this system where where obviously farmer wants to make a profit on what they've developed, but the thing is that if government looks across all the evidence base that we have currently and we see that why aren't more women using micronized progesterone when apparently that's one of the ones that's least likely to cause breast cancer down track? If that's a very clear signal there that we should be able to provide that to all women, have the option, then maybe that's where government does need to step in and go, okay, well, we're going to have a streamlined system to bring that through the TGA, and we're going to maybe discount the fees involved with doing that to the farmer just to make sure that we get that available for all women. As to the issue of safety, the problem is that we can't never roll out new products, but what the TGA will go through and they'll look at the safety data that they have based on a couple of years of testing and observation, and then they'll go, right, that's good enough for us, off we go, let's prescribe. But that still doesn't speak to what the potential long term of any medication might be in 5, 10, 20, 30 years, and that we can't possibly know that until we have that length of experience prescribing things. But we do the best we can with the evidence that we have at the time.
Thanks for that clarification. Just on a different topic now, it's moving more into the workplace and the impact of menopause on women in the workplace. And I know even Dr. Deere on the online mentioned before the stigma and silencing of women, which I think we've heard lots of evidence about in regard to workplace activities. Just wondering, I'm interested in all three of you, if you just want to give me your thoughts on the experiences that you've witnessed in women that you meet, that you obviously look after, and also how we can improve those experiences and your thoughts. Happy for any of you to start.
Linda, do you want to start?
Yes. Oh, and my voice is gone. So yeah, this is definitely a topic close to my heart, because I actually do a workplace support and education branch of Men-A-Doctor as well, and I've started to turn up in workplaces and do talks. So what do I think? I think we really need to get menopause out of the dark corner that it's been stuck in for too long, especially in places that we feel the most uncomfortable to talk about it. Most of these sorts of issues are never as bad as you think they're going to be, and the more you try and bury them, the worse they get. And also to start to realise, although men get a lot of negativity and we all assume they're going to be unsympathetic and horrible, and actually I don't think they are. They are more interested, more compassionate than we give them credit for. And and they want to understand female biology as much as the women living in these bodies. So the workplace is a really good place, I think, to show how much the stigma needs to get out of here. If you can smash the stigma in a workplace, you can pretty much smash it anywhere. And once there's no stigma about an issue, there is less of an issue. It is therapeutic for women to stop hiding this thing. But I'll also sort of say as well, we've got to appreciate some women do not want to talk about this. It is highly personal, it's highly private. So whatever you do in a workplace needs to be sensitive to that as well. And it's not like one approach is going to work in every workplace, just like one menopause consultation is never the same for every woman. So, workplace stuff does need to be tailored. You need to figure out what that workplace is like, what they want, what they don't want. So surveys of staff is a good thing before you bowl in there with loads of good intention stuff that's maybe not wanted. But I think the fear of it making women look weak or it causing more discrimination, I think that fear, like a lot of fears, is unfounded and is actually just keeping us stuck. And I think we need to be braver, and I think we need to appreciate that men are more supportive than we give them credit for. Not all of them, but, most of them. So we should be brave, and we should get into the workplace and start saying these words and being more honest.
Thank you. I'll move to either of you.
When you were talking before about an education program, I really do think men need the education, and they want it because they're affected by this, they recognise it, and they're actually in quite a position of power, particularly in the workplace, to permit this discussion by introducing the concept if they're recognising what they're seeing, which allows a person to feel more comfortable to raise it. In my personal experience, the women that I target are those who are just about to make a catastrophic decision because they can't cope anymore. I see the real crime in the delays in treatment, and that delay raises people's anxiety and distress, and so they'll make big decisions in order to manage it when it becomes critical mass for them, and this is when they can damage their career and social situations as a result. My aim is to provide care early so that women make measured decisions about what's right for them and not catastrophic reactive decisions that are not, as you say, haven't explored the possibility of support in the workplace particularly.
Yeah, I think the key thing is that women want to feel validated. They want to feel supported. They want to feel heard. They want to know that somebody is sympathetic to their experience. So if workplaces are very upfront with their policies and providing some education perhaps to people who might not be otherwise aware, sometimes that's all they need. I love what I think it was what Senator Hughes was talking about with the normalising of it. The way that the girls is like, yeah, my periods, whatever. That's what I would like to see down track. It's like it's never a question of having to talk about it because everybody knows about it, and so I think it's going to be a systemic thing that's going to gradually happen.
Excellent, thank you.